Hi everyone. My name is Lauren Waterman. I'm a consultant psychiatrist in Camden with a special interest in insomnia. And I'm also going to be presenting today alongside Hugh Selsick, who is a psychiatrist and sleep specialist based at UCLH Hospital Sleep Clinic in London. We've got an hour today, so there's quite a lot to cover. We've got a Q&A box at the bottom of your screen. If you post any questions in the Q&A box, we will endeavour to answer them during the course of the hour. Answered questions will then go into the answered tab of the Q&A box. So it's better to use that than to type in the chat, because if you type questions in the chat, they probably won't go answered. This will be recorded as well and shared with everyone at the end for a brief period of time. So today we're going to be covering a little bit about how to assess and treat insomnia. And we're going to include some CBTI techniques and also some information about medication we can use. So I'm just going to share my screen now. So to begin with, I'm going to talk you through a pathway that I created alongside colleagues, including Hugh, for North Central London ICS. Okay. Can everyone let me know if you're having any problems seeing that right in the chat, if there's any issue. So obviously this pathway is specific to our area, so it might vary slightly depending on what services are available in your area. Just very quickly before I start with the pathway, really briefly covering why we want to treat insomnia. So insomnia, it starts off normally as acute insomnia. So something happens such as somebody's feeling stressed, or they've got the flu, or it's really hot, or something's going on at home. That can lead to a brief period of short-term insomnia. But if this is untreated, it can become chronic insomnia. And once insomnia becomes chronic, it very rarely improves on its own without treatment. So it's actually a disorder that does need to be treated. Now, there's a large amount of evidence that insomnia is not just a consequence of other disorders. So we used to think of insomnia in terms of a result of someone having depression, for example, and if you treat the depression, the insomnia will go away. And actually, a large amount of evidence, including longitudinal evidence over the last 1 to 2 decades, shows that if insomnia is untreated, it's a lot harder to treat other comorbid disorders. And it also increases the chances of developing a new comorbid mental or physical health disorder down the line. So you can start off just having insomnia, chronic insomnia, and then developing other things. It also increases the chances of road traffic accidents, time off work, obesity, high blood pressure, poor diet. You can imagine if you don't sleep well, you're not going to make good life choices. And also it increases the risk of relapse from other mental disorders. So it's very important we treat it. And actually the evidence shows that the impact of untreated chronic insomnia on quality of life is similar to that of major depression and things like chronic heart failure. But at the moment, it's very undertreated around the country, in part, I think, because people are not aware of the importance of treating it and what services are available, and also due to lack of services as well. So hopefully we'll be able to cover some of that today. So this is the pathway we created for North Central London. I'm just zooming in here, but do write in the chat if you're having problems seeing it, and one of my colleagues will shout out to me. So someone presents with sleep problems. We need to do a history. So I'm not going to cover this too much now because I'm going to cover that in my first slide of the PowerPoint presentation. But essentially, you need to do quite a comprehensive assessment, looking at what might be going on, what the triggers might be, precipitators, things like that. Now, if the sleep difficulty doesn't have functional impairment, which is very unlikely. So by functional impairment, I mean some sort of impact on the daytime, like are they feeling sleepy? Are they struggling to concentrate? Are they cancelling social activities? Are they having trouble at work with their partners? Things like that. So you can offer sleep hygiene and non-pharmacological management in that situation. That's quite rare that they don't have any functional impairment from the insomnia. So usually if someone's presenting to you and mentioning sleep difficulty, it's because they've got some distress or functional impairment around it. So here in the middle, we're talking about short-term insomnia that's lasted less than 3 months. So with short-term insomnia, we recommend offering advice on sleep hygiene. Now, sleep hygiene, the evidence base consistently shows it's not very effective as a monotherapy. So around the country, for some reason, people are advised to do sleep hygiene, and actually sleep hygiene is a lot less effective than CBT for insomnia. Even a brief CBT and for insomnia intervention that we can recommend today, that you can even bring into your own consultations, is more effective than the standard sleep hygiene advice. And actually sleep hygiene was used in clinical trials as the control group for medication and for CBT for insomnia, CBTI, so it shouldn't be used on its own. But anyway, you would obviously go through those things with people, make sure there's nothing striking, like they're not having 50 energy drinks a day. And then you would look at what treatment would be appropriate. So if the sleep hygiene and the kind of initial measures are not effective, you say, okay, is insomnia likely to resolve soon? If it's likely to just be a short-term issue because they're going through something at the moment that's going to resolve, we would, consider doing a short course of sleeping tablets. So that'd be things like zolpidem, zopiclone. Temazepam is on here, but I know that's not used very often. We wouldn't really recommend starting it. That's more if someone has been on it already. Insomnia, if it's not likely to resolve soon, so for example, it's been there for more than a month, or it's chronic already, it's been there for 3 months, or equally there's sort of an ongoing stressor that's not really going to go away anytime soon. They've got an upcoming court case that's going to last months, or that they've already started behaving in a certain way that's going to prolong the insomnia, or they're very stressed about their sleep already. Then we'll move on to the management of chronic insomnia, or as I say, if it's lasted more than 3 months, you move on to the management of chronic insomnia. So chronic insomnia is when it's lasted, as I say, more than 3 months technically, or you can treat it as chronic insomnia if it's likely to become chronic, where the insomnia is happening at least 3 times a week, and where it's also causing some daytime symptoms. So the first thing we need to look at is this person appropriate for CBT for insomnia? CBT for insomnia is the gold standard first-line treatment recommended by NICE and many other national and international guidelines. It's very highly effective. So the research and audits of services providing it suggests that it's somewhere around 80 to 90% effective at treating chronic insomnia. Bearing in mind, most people who are going to those services are people who've had insomnia for a decade or more. It's effective regardless of comorbidity. So if people have comorbid PTSD, chronic pain, cancer, long-term illnesses, depression, anxiety, bipolar, even psychosis, it's still effective regardless of comorbidity. Often people, say, well, I'm concerned it's not going to work because this person also has such and such, or it's pain keeping them up at night, not insomnia. And actually, treating with the techniques from CBTI still helps that person sleep, even if there's something physical keeping them awake. Now, so first of all, we look at, is this person suitable for CBTI? And there's really very few people who are not suitable for CBTI. Essentially, the only people really who are not suitable for CBTI are the sorts of people who would not be suitable for any kind of psychological therapy. So that's the kind of people who are just not able to engage in a therapy, either individually or in a group. It's often done remotely. It's done as a group very often because it works very well as a group. It can work very well remotely as well. We talk about it more as a sleep workshop. So sometimes people worry, oh, but group therapy, I'm not so sure about that. And we say, well, actually, it's more like a sleep workshop where you're going to go once a week, maybe for 5 weeks. You're going to learn some skills that you can implement that are going to help your sleep. You don't have to kind of be talking about your past and your childhood and your traumas, or sharing anything that you don't wish to share. So it's more like a place where you go to learn skills rather than a kind of group therapy in the traditional sense. So anyone who's kind of not willing to actually do CBTI type techniques, which involves changing behaviors mostly, they're not going to be suitable. If the person has a drug or alcohol problem that would affect their ability to engage in a therapy in general, such as that they would turn up intoxicated to the sessions, if they've got very severe cognitive impairment, for example, that they won't be able to engage in a therapy. If they've got severe active psychosis or they're currently in crisis, if someone has a psychotic illness but they're not currently sort of presenting with positive symptoms of psychosis, then they should still be suitable. But obviously, if their active symptoms of psychosis would interfere with their ability to engage in therapy, then they wouldn't be suitable. Having uncontrolled epilepsy is a risk. So part of the treatment involves reducing the amount of time that people spend in bed, as my colleague is going to speak more about. So in theory, they could end up sleeping a bit less for a short period of time. It could get a bit worse before it gets better. So that's where we're a bit cautious if epilepsy is uncontrolled. In that situation, it would just be a matter of anyway discussing with the sleep clinic and seeing if they might be suitable, what modifications could be made. If they've got bipolar affective disorder, we need to be a little bit more careful with the sleep restriction stuff that Hugh will go on to talk about. It doesn't mean that the therapy can't be done though, so it just means that they might need to go to a more specialist service rather than an IAPT type service. So if they're not suitable because they can't engage in therapy, we'll look at, okay, do they need to have a longer term sleeping medication? We actually need to change this where it says sedative medication, because the main sort of first line medication that's now being used for chronic insomnia, daridorexant, is not actually a sedative. It works on a different pathway, so that actually needs to change. But for all intents and purposes, we'll call it a sleeping medication. So you could consider a sleeping medication, reviewing the need to do that at regular points in time. As I say, the first line would generally be daridorexant, and Hugh's going to talk more about that. Melatonin can be an option for those who meet the criteria for melatonin, such as those aged over 55. And if those medications are not, don't work for the person, or they're contraindicated for whatever reason, then in those sorts of situations, you might consider a long-term Z drug as an option. Now, what I really want to state is how important it is to treat the insomnia with something. So if someone's got chronic insomnia, because it impacts their health so much and their quality of life so much, they need to be having some sort of treatment. So if they're not suitable for CBTI, which would be the first line, then you'd need to be considering a longer term medication. Now, you want to review that medication after about 3 months. With daridorexant, as I say, which is the first line, it takes some time for the person to really feel the benefits of it. So we wouldn't suggest reviewing it after a week. We say around the 3-month mark is good. And at that point, you see, is it working? Obviously, if they're getting side effects, you'd review it earlier. Are they now suitable for CBTI? Can I refer them for CBTI now when I couldn't before? Is it now becoming available, for example? And you discontinue it if it's not working. And if they're suitable for CBTI, you might refer them, and then when they're having the CBTI, there could be plans made to gradually withdraw the medication as well. What you wouldn't do is see that it's effective and then say, well, it's been a few months, we need to stop it now, unless some other treatment is coming in, because there's the medication is just a band-aid, really. It's not going to cure it. So there's no reason why someone with chronic insomnia would suddenly would need a medication and then a few months later not need it anymore if they weren't suitable for an alternative treatment. So going back to the people who are suitable for CBTI, then a decision needs to be where to refer them. Now, you can start off with certain techniques that we're going to cover today that you can actually use in your consultation. I've even spoken to GPs about this, how they can incorporate it into an 8 to 10 minute consultation. Some of them are quite brief techniques where you can send the patient away and they can come back and let you know how they did. Sometimes, you might refer them for formal therapy, and you give them these techniques in the meantime so that they've got something to work with. Some IAPT services, talking therapy services around the country, are providing CBT for insomnia, either individually or in a group. Some of them are providing it for people just with insomnia, and even if they don't have an anxiety or a depressive disorder alongside it. Some of them are only providing it if the person also has anxiety or depression and meets IAPT criteria. And some of the services are not providing it at all. So it depends on your local services. So for example, in our area, we've got 5 boroughs, 2 of them are providing it and 3 are not. So it is a bit of a postcode lottery. There's also option for digital CBTI. So a lot of you might have heard about Sleepio. Sleepio, unfortunately, it does need to be commissioned, and it's not being commissioned in most of the country at the time of speaking. That might change in the future. There's an app called Sleepful, which I have no affiliation with, that is free for patients, and they seem to like it. Maybe Hugh can put that in the chat. So that's an option. And I would really use this sort of hierarchy, a sort of tiered approach like we do with depression or anxiety. Like the first one might be just kind of general psychoeducation. The second step might be using an app if they're suitable for an app. The next step might be referring them to IAPT if they're suitable for IAPT, and if IAPT is providing that service. And then you'd be looking at referring to a more specialist sleep clinic. Sometimes you might go through all steps, or sometimes you might just jump straight to the sleep clinic if the person is more complex and needing it. So this is kind of talking about just our particular area, about where we would refer. There aren't that many sleep clinics around the country providing it. Hugh, actually, can you put in the chat which sleep clinics are providing it at the moment? But it's essentially just less than a handful. UCLH in London is providing it, but I don't want to just advertise that one because I know they're already fairly inundated with referrals, but we do want you to get those referrals in. I think the waiting time at the moment for UCLH is around the ballpark of 4 months, so it's not completely awful, and I think they're sort of trying to improve that waiting time at the moment as well. So do get the referrals in, even if you're kind of suggesting an app in the meantime or doing some psychoeducation in the meantime, if IAPT is not available for that person. So carrying on. So then the next question is, say you've referred or you've given them some techniques to do, or you've got them on the app. And there's going to be a waiting list. Now, the next question to ask yourself and to ask them is, do they need to go on medication while they're waiting months for therapy? And that will be a negotiation with the patient, because really, it depends on how much it's affecting them. It depends on if they're already taking sleeping tablets. It depends on, whether the patient wants to take sleeping medication. So that's something to consider. One thing I really recommend against, and other sleep specialists do as well, is do not please give patients like intermittent sleeping tablets. Don't give them 10 a month, because then that person will sleep well for 10 days a month. They won't sleep for the other days. They'll become more obsessed with their sleep, more obsessed with sleeping tablets. And even though the physiological dependence might be a bit lower than if they took it every day, the psychological dependence can be higher because it's intermittent reinforcement. So please don't do that. I mean, daridorexant is meant for taking every day anyway, and if it's another medication like a Z drug, if you decide to give it, while they're waiting for treatment, please do give it kind of for the whole time. Yeah, so we're gonna Hugh's gonna go more through that more when we get to him. So I'm just going to unshare this. We can share this around for everyone as well who has attended today. If you would like to kind of copy something similar for your area, then I'm very happy for you to do that. If you can just send us an email just to let us know that you've done it, just so we have a vague idea of kind of where in the country is using this. Right, I'm just going to share the PowerPoint now. Okay. Oh. Okay, I can't see if this is working. Is it? Hugh, can you just nod and tell me if it's working? It is. Okay, fine. Sorry, because I can't see the red border around it for some reason. So just going to cover a little bit about assessment. Part of the assessment, you want to ask them, for example, take me through a 24-hour period. So, for example, when do you go to bed? Like a typical 24-hour period. Let's talk about last night or last week, if that's more typical. What time do you go to bed? Okay, you go to bed at 10 p.m. Right. What time do you fall asleep? You fall asleep at 1 a.m. All right. So what are you doing between 10 and 1 when you're trying to sleep? You're lying in bed, tossing and turning. You're on your phone. Okay. And then how much time during the night do you spend awake? How many times are you kind of waking up and are you struggling to get back to sleep? Bearing in mind that actually waking up is completely normal. So as humans, we actually wake up several times an hour on a physiological level. That's why we never fall out of bed, is we always kind of like check our surroundings, readjust our position. But if someone sleeps well, they tend to wake up briefly, they fall straight back asleep, they don't really think anything of it, and they don't remember it the next morning. But if someone's got insomnia, they might wake up and be thinking, oh gosh, I've woken up now, I'm not going to get back to sleep. And then they struggle to get back to sleep, and then they will remember it and they'll be able to tell you about it. So it's not actually the waking up that's the issue, it's how long it's taking someone to fall back asleep. Then you want to know, okay, when do you finally wake up the next morning and how do you feel in the day? How's it affecting your functioning? Okay, and then in terms of being able to, quantify, is this a chronic insomnia? How often and for how long has this been going on? So chronic insomnia by definition is 3 times a week for 3 months. Contributing factors. So you want to kind of go through all the different things that might be leading to insomnia. So we don't talk about insomnia causes because insomnia is a disorder on its own. It doesn't just get caused by one thing. But we can talk about precipitating or prolonging factors that might be contributing to the insomnia that we might be able to modify. So homeostatic drive, that's the kind of inbuilt drive in your brain to fall asleep. That's something that builds up through the day, and I know Hugh's going to cover that a bit more later. So that might be that the person is napping a lot in the daytime, or they're sleeping in the morning, and that is leading to them not having enough homeostatic drive to fall asleep by the time nighttime comes. So you might want to talk to them about that, and we'll cover that more in the CBTI section. Circadian, so have they got a circadian rhythm disorder, which I'll cover in a bit as well? Are they having issues with jet lag or shift work? Do you need to write a letter to the employer asking for kind of them to come off of shift work for a period of time, for example? Physical, so have they got chronic pain, urinary issues, for example? Is there a sleep disorder also that's going on? Have they got sleep apnea? As I said, that doesn't really affect the treatment. So CBTI is still effective regardless of physical health problems, but it might be that you can optimize the treatment of those physical health problems, and that could help the insomnia as well. Although it doesn't usually treat the insomnia on its own once insomnia has become chronic, because insomnia is very much a kind of psychological, behavioural and cognitive disorder. Environment, so have they got issues with housing, noisy, light, hot, that they can correct easily? And substances, things like medication, are they taking SSRIs or venlafaxine in the evening? Could they switch it to the morning so it's not impacting their sleep? Are they on other medications that are impacting their sleep that you could adjust? Could you switch them, for example, from a non-sedating antipsychotic to a sedating antipsychotic, or change the timing of when they take it? And then also things like caffeine, drugs and alcohol that you might want to speak to them about. Just going to quickly go through some of the common other sleep disorders that someone might have that might present as insomnia or that might be comorbid with insomnia. So restless leg syndrome, it can sometimes present similarly to akathisia, but it does have some differences. So the 4 criteria is you want to ask someone, do you get an uncomfortable sensation, usually in the legs, but it can be anywhere, but it's usually in the legs. So do you get this uncomfortable sensation in your legs? Is it worse at night? Is it worse at rest? So obviously that's different from intermittent claudication, for example. And is it temporarily relieved by movement? So do you feel like you want to kick out? And when you do kick out, does that actually help relieve it temporarily? People actually rarely mention restless legs, so they more likely talk about difficulty falling asleep. So it is something you need to actually actively ask, is this stopping you sleeping? Is this a problem? You'd also want to check, is there a circadian rhythm disorder? So the most common is delayed sleep-wake phase disorder. This usually starts in adolescence, and it's where the internal body clock is delayed relative to the outside world. So they don't get sleepy until very late. So it sort of presents itself as a sleep onset insomnia. And they will usually sleep in quite late in the morning if they're allowed to. For example, they might do this at the weekends, but during the week they're not allowed to, so they just don't get enough sleep. And they feel sleepiest in the morning, so they're kind of traditional night owl type people. And they're most alert late at night. Now, the key question you can ask here that will really help differentiate it from sort of from insomnia disorder is, if society let you sleep from, let's say the person falls asleep at 4 a.m. and they sometimes sleep till midday. If society let you sleep those hours and you could get up and go to work, in the afternoon, would sleep be a problem? And if they say no, that would get over the whole problem of the sleep problem, then you know it's a circadian rhythm disorder. If that wouldn't resolve the problem, they still have a problem with their sleep, then it's more likely to be an insomnia disorder. So if the person is very sleepy in the daytime, you might want to consider they might have a comorbid sleep disorder. So insomnia alone actually very rarely causes people to be sleepy in the daytime. Insomnia, obviously if someone has short-term insomnia that's for a few days, then they might feel very sleepy in the daytime. But once someone has developed chronic insomnia, their brain has started to adapt. And there are these wakefulness pathways in the brain and these sleepiness pathways. And the wakefulness pathways start to gradually become in overdrive. So actually, they're quite wired in the daytime because these wakefulness pathways have adapted to keep them awake, even though they're not sleeping. So we refer to them often as tired but wired. So actually, people with chronic insomnia very rarely just drift off to sleep in the daytime. Maybe the exception is after lunch, a heavy lunch or something, but generally they're not feeling that sleepy. The problem is they actually can't sleep in the day or the night. If they are sleepy, you might want to think, is this another sleep disorder or is there a comorbid sleep disorder? So a way to look at daytime sleepiness is with the Epworth Sleepiness Scale. So if someone falls asleep in the day, you want to consider have they got obstructive sleep apnea or for example, periodic limb movements. So that's when people are kicking out and the bedclothes end up all over the floor while they're sleeping and that wakes them up. You can do the stop bang questionnaire to screen for obstructive sleep apnea. And if any of this is likely, refer to a sleep clinic. And also, as I say, you can have sleep apnea and insomnia comorbidly. So if a lot of people with sleep apnea also have insomnia, so they might also have trouble getting to sleep or staying asleep, especially staying asleep, which we call middle insomnia. So I'm going to run through principles of CBTI. So I'm going to start with stimulus control. So, first of all, CBTI principles. Okay, so the principles are that the rules are different if you have difficulty sleeping versus if you're a good sleeper. So often people say, well, so-and-so drinks coffee before bed or so-and-so reads in bed and such and stuff. And I say, well, if that person sleeps well, it doesn't matter what they do. But if you have a problem with sleep, then that's when you need to change what you're doing. If you sleep very well, you don't need to follow the guidance strictly, but if you're a bad sleeper, those rules are for you. And the more strictly someone follows these CBTI rules, the quicker their insomnia will improve. So sleep stimulus control, I'm just going to give a very, very quick recap of what is classical conditioning, because I'm sure everyone here has learned it before. So just to remind of Pavlov's dogs. So just to remind you, what is a stimulus? So an unconditioned stimulus for the dog was food, and the bell was a neutral stimulus. So the bell didn't cause the dog to salivate, but the food did. And when the bell and the food were combined together, the dog salivated. That was the unconditioned unconditioned response. And then when the bell was given on its own, so previously the bell didn't lead to salivation, now it does because it's been conditioned to. And that's what happens with the bed and the bedroom. Person with chronic insomnia experiences such that the bed in the bedroom has become a stimulus for keeping them awake and alert. So someone who sleeps well will go to the bed in the bedroom and they will feel sleepy and they will fall asleep. Someone with chronic insomnia will go to the bedroom and it will make them feel angry, anxious, frustrated, and be awake. So often, if you say to someone with insomnia, you ever find that you're on the sofa, you're feeling really sleepy, your eyes are drooping, you get into bed, you turn off the lights, get under the covers, and boom, you're wide awake, and say, oh gosh, all the time. That's because the bed in the bedroom has become a stimulus for keeping them awake. Now, this is a really strong reaction, and it's even more strong in humans than it is in dogs. But the good thing is that it means that reversing this reaction is a very powerful way to treat insomnia. So quickly, when we ask people, what do you do in your bedroom? People come up with things like this. Talking on the phone, reading, social media, arguments, working, all sorts. So one way that we reverse this is we say, okay, the bedroom needs to not be a stimulus for all these activities that are very active and alerting. It needs to become a stimulus for sleep. So we need to recondition it. So we say you should only be using your bedroom for sleep, having sex, and getting dressed. Because these are the three things that have to be really done in the bedroom in certain situations. So we say these three things and nothing else, but really nothing else. People say, oh, what about sleep? What about reading? Reading helps. I say, well, it's not helping enough. So often people feel like, the reading, it's something that's helping them. And it's like we use the analogy of like clinging onto the branch of a tree, and they're scared to kind of let go of that branch to climb up. But to climb up, you have to let go of the branch. So they have to let go of the types of things they were already doing to try and improve their insomnia. And sometimes it does take a bit of conversation to kind of make people feel safe to do these things, to let go of those techniques and to pick up the ones that we know really work for the vast majority of people. So there's three key techniques in terms of sleep stimulus control. So there's moving activities out of the bedroom. If someone is in a studio apartment and they can't move out of the bedroom, at least a next best option is moving out of the bed area. So for example, can they get a Japanese screen around the bed? Can they make the bed look different in the daytime and the nighttime, like cover it, putting the sheets on, putting some throw, cushions on it and stuff? At least, not to sit on the bed, even if they're on a beanbag right next to the bed, it's better than lying in the bed, because then the bed is going to feel the same as it does at night. And the second thing is not to go to bed too early. So we're trying to reduce the time people are spending in their bed that are not sleeping, to recondition the bed as being a stimulus for sleep. So if people go to bed too early, they're probably not going to sleep, and then they're going to be lying in bed tossing and turning. That's going to increase this contingent response as the bed being a place that keeps them alert. And the other rule is, we call it the 15-minute rule. And it's that if the person has gone to bed and they've not fallen asleep, and it's been somewhere in the ballpark of 15 to 20 minutes, we don't want them watching their clock. It's just when it feels like it's been 15 to 20 minutes, they need to get out of bed, go to another room, go to the living room, whatever, and just do something nice that they enjoy. We're not too restrictive on this, but obviously they're not going to want to watch like a horror movie or something, but they can watch a bit of TV. Blue light we're more worried about with adolescents, but in adults maybe it affects them a bit, but we're not really sure. Some people it affects more than others. Or they can read a magazine, or they can do some cleaning, or do something that's going to enhance their quality of life rather than lying in bed tossing and turning. So that's the other benefit, is that it actually gives them more time when they can do things they enjoy rather than just lying in bed feeling anxious. So those are the kind of techniques you can talk through with them, obviously depending as well on which of these the person is doing more of. When to go to bed, I think we are on, oh no, I'll talk about, Hugh's going to cover that. Okay, sleep scheduling. I'm going to pass over to Hugh Selsick.
Thank you very much. Okay, so let me share my screen. If you can unshare, Lauren. Let me see, maybe I'll... Okay. Sorry, everyone, I'm down with a bit of a cold, so I'm hoping that my voice will last to the end of the session. So I assume everyone can see that. Give me a nod, Lauren, if you can, and assuming you can hear me then. Okay. So I'm going to talk you through this technique of sleep scheduling, which we use as part of CBT for insomnia, but it's also one of the techniques that can be really useful as a kind of standalone technique when you've got 10 minutes with a patient in an outpatient consultation or a ward round, and you want to deliver a really effective technique. You can deliver this, and I'm going to give it to you really in two ways: the full technique, the whole thing, and then I will give you a simplified version that you can use where patients may not feel that they can do the full version. So the first thing we want to do is to explain to patients about that homeostatic sleep drive that Lauren mentioned, that from the moment we wake up in the morning, we start to accumulate sleepiness. We're building up sleepiness. And then if sleepiness is the fuel that drives your sleep, the analogy I like to use is that what you're doing during the day is filling up your sleep tank with sleep fuel. And then when you fall asleep at night, you use up that sleep fuel. And when the tank reaches empty, you wake up again in the morning and uh, the cycle repeats. Patients say, is this just an analogy or is this sleep fuel a real thing? And we think it is a real thing. We think that the substrate for this is adenosine, which builds up as you break down ATP during the day, and then gets reconstituted back into ATP at night. And adenosine, in addition to being a waste product of energy usage, is also a sedating neurotransmitter. So with this in mind, the first thing that we ask patients to do is to start filling their tank at the same time every day. Most patients with insomnia have been told that they should go to bed at the same time every night, and that turns out not to be great advice. What is much more important is to get up at the same time every day. Because if we have a patient, for example, who's waking up here and he fills up his tank and his tank reaches full over there at say 2 in the morning, so he's waking up at 7 and his tank reaches full at 2, and then he sleeps for 5 hours, wakes up at 7, and so on. But suppose that this patient then on a Sunday morning lies in for a couple of hours and he only wakes up at 9. If he's filling up his tank at the same rate, his tank is only going to reach full at 4 in the morning. And so instead of falling asleep at 2, he's now going to fall asleep at 4. And this is why most people sleep worse on a Sunday night than any other night of the week. So we ask patients to set an alarm for the same time every day. That way they start filling their tank at the same time every day. That means the tank will reach full at the same time every night and they will feel sleepy at the same time every night. And that will naturally make the bedtime more consistent as well. So first step is to anchor your rising time to the same time every day. Really importantly, you don't want to leak out any sleep fuel during the day. And the way that sleep fuel would leak out is if you fall asleep, whether that's taking a siesta or nodding off during my talk. Any sleep you have during the day is going to allow some of that sleep fuel to leak out. And patients will often say to you, but I need to have a nap in order to catch up on the sleep I lost last night. And what we need to explain is that you're not catching up on sleep from last night. If you nap today, you're stealing that sleep from tonight. You're going to make it harder to fill up the tank tonight, and you're making tonight's sleep worse. So avoid napping if at all possible. Okay, now we get to the slightly more complicated bit. We explain to patients this concept of sleep efficiency, which is simply what percentage of the time that you're in bed are you actually asleep? And this is quite a good measure of sleep quality. So, for example, someone who's in bed for 8 hours and asleep for 6 hours, they'd have a sleep efficiency of 75%. And this is the way that we work it out, is we say you take your total sleep time, uh, divided by your time in bed, and we multiply that by 100 to make it a percentage. And a normal sleep efficiency is around about 90%. Now, when we're doing this, what we don't want to do is just look at a single night. What we ask patients to do is to keep a sleep diary for a week or two and calculate the average sleep efficiency across the week, because there's always going to be variability, and we can smooth that variability out by getting a week's worth of data. Okay. What we then want the patient to do is we want the patient to go to bed only when their tank is full, when their tank is full of sleep fuel. Because if they go to bed before their tank is full, one of two things will happen. They'll either lie in bed for ages waiting for that tank to fill up before they eventually fall asleep, or they may fall asleep when they get into bed, but because they're falling asleep without a full fuel tank, partway through the night, they're going to run out of fuel and wake up. And therefore, their night's going to be fragmented. They're going to have long periods of wakefulness in the night, or they're going to wake up early in the morning. So we want them to go to bed here where the tank is full. And again, what we do is we go back to their sleep diary and we look at their average sleep time across the week. and we subtract that average sleep time from their rising time, which should now be the same time every day, 7 days a week. So let's say someone is sleeping 6 hours, 15 minutes on average, and their rising time is 7 o'clock. We say 7 a.m. minus 6 hours, 15 minutes. That takes us to 12:45. And this is now the patient's earliest bedtime. There is one proviso. If the patient feels that they are sleeping less than 5 hours, they're probably not, but if they feel they're sleeping less than 5 hours, we simply say rising time minus 5 hours, which then gives us an earliest bedtime. So if they're sleeping 3 hours at night but getting up at 8, we would say 8 o'clock minus 5 hours. Your earliest bedtime is 3 a.m. And now the rule of sleep scheduling is simply this. You can go to bed when you have met two criteria. A, you are feeling sleepy, and B, you have reached that earliest bedtime. If you feel sleepy before you get to the earliest bedtime, you push through to the earliest bedtime before getting into bed. Conversely, if you get to your earliest bedtime and you're not sleepy yet, you wait until you're sleepy in order to go to bed. Now, you do this for a week, and while you're doing this, you carry on keeping the sleep diary. And at the end of the week, we recalculate the sleep efficiency. So average time of sleep divided by average time in bed multiplied by 100. If the sleep efficiency is still below 85%, then they're clearly spending too much time in bed, and we ask them to then move their earliest bedtime 15 minutes later for the subsequent week. Unless they are already at that 5-hour floor, in which case they just keep it the same. If their sleep efficiency is 85 to 89%, you keep that bedtime the same for the following week. But if the sleep efficiency hits 90% or above, the following week you can move your earliest bedtime 15 minutes earlier. So give yourself potentially a little bit more time in bed. And what we're doing here by doing this is we're compressing the time in bed down to consolidate the sleep and give them a much better quality of sleep. And then very gradually, we're going to increase the time in bed to improve the quantity as well. Now, you will have these slides, and it'll be fairly easy and straightforward to work through it. But if you have patients who just don't feel that they want to do the maths or can do the maths, there is a simplified version. Say to them, whatever time you go to bed, let's make that your earliest bedtime. And every week, I'd like you to move that earliest bedtime 15 to 30 minutes later, depending how brave you feel. When you get to a point where you are falling asleep within 30 minutes and you're not awake for more than 30 minutes in the night, stop compressing the bedtime, have a week or two of stability, and then you can experiment with moving the bedtime 15 minutes earlier each week. And if that's going well, fantastic. But if at any point you find that your time taken to fall asleep or your time awake during the night starts to exceed 30 minutes again, you've increased too quickly. So you compress again by 15 or 30 minutes, let it stabilize, and then try increasing again. Okay. So those are the two really sort of core brief behavioral interventions we'd recommend. And I'm going to move on now to talk very quickly about medication. There's a huge amount to talk about here, and I'm not going to be able to cover it in much detail, but I want to just give you a way of thinking about medication that you can use with your patients. The first thing that's worth looking at is which chemicals promote sleep. And there are really very few: GABA, melatonin, and adenosine. And so clearly anything that promotes their activity is going to potentially be helpful in treating insomnia, whereas anything that inhibits their activity is going to wake the person up. There is a much longer list of neurotransmitters that promote wakefulness. And so if we want to use a medication acting on these neurotransmitters to promote sleep, we need to use something that inhibits their activity. So for noradrenaline, we might use trazodone, which has anti-noradrenergic activity, or we would use an antihistamine in order to promote sleep. As a good rule of thumb, the degree of sedation you get with most medications, not all, but most medications, fairly closely correlates with their plasma levels. So if you understand the pharmacokinetics, you have a really good idea of when these drugs are likely to work. You want a drug that's got a relatively short Tmax, something that kicks in quickly. And really, then you want to look at the half-life. If you've got someone who just has difficulty getting to sleep but no difficulty staying asleep, you may want to use a short-acting drug like zolpidem or melatonin. If the person's got more difficulty later in the night, you want a longer-acting drug such as zopiclone, daridorexant, or temazepam. The payoff, though, is that if you do use a longer-acting drug, you do have a higher risk then of daytime sedation. So things to consider when you're prescribing are, can you treat insomnia and the comorbid psychiatric condition with a single drug? And I'm talking very much about off-label, off-license prescribing here, but it's something we very commonly do. That you've got a patient with insomnia and depression, we might give them a sedating antidepressant to treat both. Do they drive? And if so, then shorter acting drugs might be better. And I tell my patients to avoid driving for 13 hours after taking zopiclone or 9 hours after taking a zolpidem or daridorexant. Are they a sole carer for someone in the night? For example, a single mother who may have to attend to their child in the night, in which case you would be a bit cautious about giving them something sedative. Um, it would be ideal to avoid meds in this circumstance, although daridorexant doesn't seem to raise the arousal threshold. So this might be your best choice if you do need some medication. And then really importantly, when in the night do they have the problem? Is it difficulty getting to sleep, staying asleep, or waking up too early, or a combination? Because then we can go back to those pharmacokinetics, and that will tell us which drugs we should use in which circumstance. So as I said, if it's just initial insomnia, difficulty getting to sleep, you can use a short-acting medication like zolpidem or melatonin at bedtime. You can use sedating antidepressants here, and we tend to use low-dose mirtazapine or trazodone in our clinic quite a lot. But because it takes longer for these medications to kick in, they have to take them an hour or two before bed to get the effect. If they have middle of the night insomnia, then again, a sedating antidepressant can be useful, or a longer acting hypnotic like zopiclone or daridorexant, and because it's only in the middle of the night, it doesn't matter if it doesn't kick in quickly. So you can take all of these at bedtime. If it's terminal insomnia, which is a term you should never use with your patients, we'll talk about early morning waking, then you would use a longer acting medication like zopiclone, daridorexant, or a sedating antidepressant again at bedtime. But very commonly, what you see is all three. It's very rare that a patient has a problem only in one part of the night. They have difficulty getting to sleep, staying asleep, they wake too early in the morning. And so here again, we are generally leaning towards the longer acting medications, zopiclone, daridorexant at bedtime, or mirtazapine, trazodone an hour or two before bed. Again, just be aware of the risk of daytime sedation and don't rely solely on medication. When you put pen to paper to prescribe a hypnotic, that should be the cue to start doing behavioral interventions as well, if they haven't already been done. Now, it may surprise you that when I was talking about all of these ways we treat insomnia, the one thing I didn't mention is promethazine. And we've seen a huge upswing in promethazine prescribing in the last few years. And antihistamines can be very good for sleep maintenance insomnia because they tend to have a long half-life and the peak sedation may occur sometime after the peak plasma level. So they're good for middle of the night, end of the night insomnia. The problem is that the antihistamines that we have, such as promethazine, diphenhydramine, are also very powerful anticholinergics. They carry an anticholinergic burden score of 3, which increases the risk of side effects such as tachycardia, constipation, urinary retention, dryness, delirium in older adults, and it increases the risk of dementia. And so these are not particularly safe medications because they're not prescription medications or controlled. It's easy to fall into the trap of thinking, oh, they must be safer than prescription drugs. But actually, we don't think that that's the case. And so for me, the only time I would consider using promethazine is in pregnancy, simply because there's a lot of data, or a lot more data on promethazine in pregnancy than any other drugs. But for particularly longer term use in other patients, I would steer clear of it. So take home messages are sleep hygiene is really effective and that's rarely, not really effective. And CBTI is the first line treatment. It's cost effective. It's clinically effective. We need to roll it out to far more patients. insomnia severely impacts quality of life, and so it should never be left untreated. And there are times when there's a role for medication. Um, and use these brief behavioral interventions with your patients. You can often make a really big shift in a patient's sleep just by using one or two of these techniques. Okay. And if we have piqued your interest, particularly in the CBTI, the college will be running a 1 day CBTI training course in October, and Miriam is going to put up the details of that. So please do have a look at that. And we will now try and address as many of the questions as possible. Um, okay, so let's start at the top. Uh, Vinod's asked, are there any practical rating scales you can use on adult wards? And to be honest, clinically, there are very few scales that we use in sleep medicine. There's the Epworth Sleepiness Scale, and the Stop Bang is a decent screening questionnaire for obstructive sleep apnea. But other than that, no. Sleep medicine is done on clinical history rather than on rating scales. Um,
And
Urshad's asked, are there adaptations of CBTI for people with learning disabilities? Lauren, do you want to comment on that?
oh no, 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 you answer that one. I was going to comment on something else.
Okay. Yes, there are. So for example, we would use the much more simplified version of sleep scheduling. Um, the we give a lot of information. It's quite didactic uh, in CBTI, and so we would simplify the information. We would perhaps pare it down to the bare essentials, but also really importantly, bring carers in to help them support the patient. Um, Bearing in mind also that a significant proportion of patients with learning disability may live in supported accommodation or care home settings, and we need to adapt some of the techniques for the fact that they may only have one room to live in. They don't have necessarily, a whole house, uh, and that affects how we do things. So, yes, there are some adaptations, but the core techniques remain very much the same.
I'm
Um,
just looking at what questions there are. So there's a few that I can group together. So there's a couple of questions about daridorexant use in people with mental health problems. I think it's quite an important question to answer, given that there are a lot of psychiatrists on this webinar. So in the BNF, it does mention caution in people who have suicidal thoughts and depression and severe mental illness. Now, that has not come from the specific trial data for daridorexant. That has come from general caution for using any sleeping tablets in people with mental health problems or suicidal thoughts, and also the knowledge that people with with chronic insomnia are likely to may have suicidal thoughts or comorbid illness that needs monitoring. So it's important to say that there were not concerns about specifically for daridorexant, and that daridorexant actually is not a hypnotic. So the concerns of for other hypnotics in people from the psychiatric populations don't really apply to daridorexant. And also that we've got some, a fair amount of real world data for daridorexant and for other similar orexin inhibitor drugs, for which it has been shown to be quite safe. So I would just say you can start it in psychiatric populations, but just monitor them as you would generally anyway. In people with insomnia and psychiatric illness. There's a question about role for polysomnography. You would want to. Oh, sorry, Hugh, did you want to pipe in?
yeah, sorry, I just thought seeing as we're on redirection, why don't we address all of the questions there? So
Yes.
there were a couple of questions about using it in older adults. Certainly the original trials, over a third of the patients were over 65. They recommend caution over 75 due to there being less data and no data over 85. But dose adjustment is not needed in older adults. You only really need to reduce the dose if there is a liver dysfunction, because it's so potently metabolized in the liver. There was a question about using it in dementia. We have no data whatsoever. But theoretically, you would expect it would probably be reasonably safe because it acts on a very limited pathway in the brain. It doesn't take a shotgun approach to the brain. So, um,
I've
you
answered
know,
questions already. I've typed in
uh,
the answer section as well, while you were talking, Hugh. But yeah, so I sort of I've explained as well about the fact that, trials, it didn't show an increased risk of falls, even at the 50 milligram dose either, or increased risk of urinary problems.
and
But
I think it's worth saying actually about hypnotics. There's been a recent study showing that we know there's an association between hypnotics and falls, but this study looked at looked at it longitudinally, and what they showed is actually the highest risk of falls was in the 3 months prior to being prescribed the hypnotic, suggesting that it's the insomnia and untreated insomnia is what increases the risk of falls more than the medication itself.
there's also a question about uh, if GP practices are commissioned to prescribe daridorexant. So daridorexant has been recommended by NICE for GPs to prescribe even from the first prescription. So we don't need a shared care agreement like we do with antipsychotics and mood stabilizers. They can start them, and that's because insomnia is very commonly seen in primary care. So that was why NICE approved it for primary care prescribing. But we do know that there are some areas where GPs are kind of maybe feeling anxious about this. They don't have much knowledge of it, for example, and that's why we worked with our GP colleagues and the ICS pharmacy team to create that flow chart and sort of get the go ahead for GPs to prescribe it. So you can feel free to get in touch with me if you'd like to kind of discuss how we went about that and if I can support with that. I was just looking at, because obviously, unfortunately, we can't answer everything in the next 3 minutes. So I was just looking at what might be particularly relevant to this talk. So there was, is CBTI widely available in the country? If we need to train, how we can go about it. So as I say, in October, we're running a training course. I think, can someone share that slide? Actually, it was mentioned about the training course that we're doing. It's a 1-day training course, 3 RC Psych, but there are also other ones around the country as well. If you can't make that particular date, for example, UCLH Sleep Clinic does one. And there was a question about, is being under mental health crisis team a contraindication to CBTI? It's not an absolute, you can still use the key techniques from CBTI. The thing we need to be more cautious of if someone is in crisis is the sleep scheduling. It just needs to be done in a more cautious way. But there's the techniques that are always going to be useful. But in theory, if you're compressing the amount of time that someone is in bed for, then it could reduce the amount of sleep that they get temporarily. In practice, I don't see that very often. Usually, people's sleep actually improves from fairly early on, but sometimes it can, in theory, take some weeks for it to get better after getting worse. CBT, is it widely available in the country? Unfortunately, fortunately not. But please do lobby your kind of local area to try and bring it in, for example, local IAP services or secondary care services.
There've been a lot of questions about numerous medications, Z drugs, daridorexant, melatonin. How long can you prescribe or should you prescribe for? And again, this is outside of the license, but our feeling is you should prescribe for as long as the patient is benefiting, as long as the benefits outweigh the risks, because you don't want to leave insomnia untreated. So, there's no need to rush patients off medication if they're doing well on it.
I think if you can give a decent rationale, then that's what's needed. So, for example, that this person has chronic insomnia, it's severely impacting their life in these ways or causing them a lot of distress. They're not suitable for CBTI, or we've tried CBTI and it's not worked. They're really keen for medication. They say medication helps them sleep and improves their quality of life. There's no reason to believe that this has, that this problem has gone away because it's chronic and they're not able to have CBTI or whatever. And therefore, we've balanced the risks and benefits and decided to continue this medication long term. That would be kind of quite a robust rationale, in our opinion, for actually continuing it longer than usual. Obviously it needs to be a case by case basis. There was a mention about half-life. Why zopiclone has a half-life of, so I mean zopiclone has a longer half-life than zolpidem. So if someone has problems getting to sleep, you might recommend more zolpidem. for short-term prescribing than Zopiclone. But if they're struggling to stay asleep, you might think about Zopiclone, or you try one and then you go for the longer one if it's not long enough. But daridorexant has a longer half-life. Because it's not a sedative, it doesn't cause, even though it's got a longer half-life, it doesn't cause this drowsiness in the morning as much because it's not working on the sedative pathways. It's not a hypnotic. But it can help them through the night. Melatonin again is more helpful in early insomnia because it's got quite a very short half-life. Wonder if we need a half day on this. Yeah, I mean, do consider the course in October. Under 18. I mean, this talk was more aimed about adults. Daridorexant isn't licensed for under 18, so it's not in there. Here's
So they
only
are doing a trial at present on under 18, so we may have some data on it in the near future.
There were quite a few questions as well about that I've moved across that about shift working for doctors and jet lag and that kind of thing. Unfortunately, just because of the time, we just don't have really long to cover that. I don't know if you have a couple of sentences to summarize. I mean, it's
Yeah, look, there's no good way to do shift work. Our bodies aren't designed to do that. And one of the things that we will do, for example, if someone's got insomnia and they do shift work, is really advocate for them to come off shifts until their sleep is much more resilient. Um, but a lot of it really comes down more to organizational things, designing shift rotors correctly so that you go from early to late to night to off rather than moving earlier, from a late to an early, because your body doesn't adapt to moving early as easily as it does to moving later.
They mentioned about LD, people with LD. I mean, you can still do CBTI if it's like mild LD, for example, but you just might want to do it one-to-one so you can go at their pace rather than in a group. Same as someone has a history of psychosis and they've got negative symptoms, for example, you might want to again do it one-to-one. Just if someone just generally is going to struggle in a group, then that would be kind of the adaptation. Power naps. So if someone struggles to, we want to get people sleeping at night, so we don't advocate for power naps. If someone absolutely has to nap and they just can't possibly stay awake, then keep it as short as possible, like set an alarm for 15 minutes later. But it's much better to get them sleeping at night. So every time you have even a short nap, you're taking a huge chunk of that sleep fuel that's meant to be building in the day. And it means that by the time it gets to nighttime, you're not going to be as sleepy and it's going to take you longer to sleep. So we really sort of try and stay away from the power naps.
Unless you're a good sleeper and you're
Yeah.
sleep deprived, which is different from insomnia, in which case a power nap is a good idea. If you've just done a night shift and you're exhausted, but you have no difficulty with your sleep generally, then absolutely, have a power nap.
Will sleep diary not be a distraction for someone with insomnia? So we don't want them keeping it next to the bed. They can leave it in the kitchen or put up on the fridge or something. So they fill it in first thing in the morning while they remember how their sleep went. But we don't want them filling it in bed because then it would be a distraction. Um,
As someone's asked about the difference between using immediate and slow release melatonin. We use immediate release melatonin mostly for circadian rhythm disorders where you want a nice discrete pulse. And the slow release more for insomnia where you want it to, not only get them to sleep, but keep them asleep a little bit longer as well.
Yeah, so if it's kind of like a social jet lag as well, that's also a circadian rhythm type thing, then you might use the immediate one to kind of
Yeah.
give them like a boost. But in that situation, you'd often give it several hours before bed rather than like right before bed. So you want to give them this boost and it just kind of shifts their whole melatonin cycle up rather than it kind of being used as a sleeping tablet. Herbal remedies. I mean, if someone thinks a herbal remedy, if they find it helpful, then by all means use it. I mean, even if it's a placebos are very effective for sleep. So it doesn't mean that they shouldn't be used. If it's something that's harmless, then why not? Things like chamomile, but obviously be cautious of anything
There's
stronger.
a little bit of data from placebo-controlled trials for passion flower and ashwagandha root. So, if patients want to go down the herbal route, that's what I'm usually steering them towards. Um, the, did you get to answer the question about polysomnography, Lauren?
No, I didn't. I mean, I suggested, you'd want to refer to a sleep clinic if you were concerned about someone having a comorbid sleep disorder. So, for example, if they were sleepy in the daytime, it's unlikely to be insomnia on its own. So, or if they report, sleep apnea symptoms, or that they're, kicking out, or sleepwalking, or that their bedclothes are ending up on the bed, they're kicking their partner in their sleep, so they're likely to have, they might have periodic limb movements or something, then you'd refer them for sleep clinic, and then the sleep clinic would judge about polysomnography.
There are a number of questions kind of asking about using CBTI medication in different age groups, and so I'll just run through that quickly. Is CBTI suitable for children and adolescents? Absolutely. Um, we do modify it a little bit, again, for children and adolescents, but it is certainly effective. Can you use it in is there a difference between how you would treat younger adults and older adults? For the most part, not really. With dementia, the one thing that we would really advise is to be really vigilant about sleeping in the day. Studies have shown that, particularly in care home settings, people with dementia can have as many as 20 or more discrete sleep episodes between 7 a.m. and 7 p.m. And then people wonder why they can't sleep at night. So really focusing on keeping people awake during the day, or reducing napping to just a very short planned nap at some point can improve sleep at night. Uh, does
So
CBTI work in neurodivergent people? Absolutely. Again, some modifications can be useful. For example, in ADHD, the advice is to kind of keep sessions a bit shorter, and a little bit more focused, and maybe do it over a longer period. Um, for patients with autism, uh, what can be useful also is really to take a closer look at the environment, because the kind of thing that may not affect you or me, a blinking light on on a turned off radio or something which wouldn't bother you or me, might be very problematic for them. So when we do CBT with them, we do a deeper dive into what kind of environment they're sleeping in. Um,
the question about, so someone said, I tend to use low dose promethazine for adolescents as it's safer in overdose than benzos and Z drugs. Do you think this is safe? It,
I mean, I'm not entirely sure it is safer, because, as I say, it's got such, it's got this anticholinergic activity, and that has cardiac side effects. So, it's questionable as to whether it really is safer. I think people do tend to overdose on it less just because it makes them feel awful. It's not a medication that, when you take it at night, you can often feel really groggy and unhappy during the day. And so, uh, we don't tend to see people taking more than the prescribed dose.
but yeah, I mean, it's if they're at high risk, that individual person is at high risk of overdose. Obviously, you would need to be cautious of benzos and Z drugs. Giving it to them on a daily basis, or just giving them a few at a every few days. If they're not someone who tends to stockpile, but obviously you need to weigh up the risks and benefits. But yeah, probably not a great option. Maybe something like melatonin might be a safer option to consider than promethazine. There was something about melatonin dosing. Do you want to talk about that, Hugh?
Yeah, so the dose of melatonin depends on the indication. So for circadian rhythm disorders, we like to start really low, maybe 1 milligram, 2 milligrams. Uh, for insomnia, I mean, it's only licensed at 2 milligrams in over 55s, not because your physiology changes dramatically when you turn 55. It's just that the trials for this particular formulation were done on over 55s, and that's the license that it got as a result. Um, there is some evidence to suggest that going up to about 6 to 8 milligrams, you might get increasing effect, but that above that level, the dose response curve is pretty flat, and you don't get much additional benefit. If we are using it to treat REM sleep behavior disorder, at the moment we go up to 16 milligrams. And it's worth saying that the highest dose given on a repeated basis in clinical trials was 300 milligrams, and there were no significant adverse events. So, 16 milligrams sounds alarming because it's 8 times the licensed dose, but that's actually well within the dose range that's been used in trials.
Also, if sometimes with melatonin, less can be more. So actually reducing the dose might cause more benefit. So it's not just a matter of the more you give, the better, especially if you're giving it for circadian rhythm disorders and you're giving it a few hours before bed in immediate release form. Sometimes even giving 0.5 mg or 1 mg versus 2 might be even better than 2. And, giving more than that isn't necessarily helpful because it's more about you don't want to shift the cycle too much, but you don't want to shift it too little. So sometimes it's a bit more of a trial and error with the dose and the timings. There was a question about quetiapine for insomnia and anxiety. I mean, it can be helpful for insomnia. It can be helpful for anxiety. But it's not, it shouldn't be used on it. If someone doesn't have another indication for quetiapine, it shouldn't be used because quetiapine does also come with side effects, anticholinergic effects, for example. It can cause dizziness and things like that, and cardiac effects. So, it shouldn't be, it wouldn't be the best medication to consider for just insomnia unless there was another indication for quetiapine. Some people find that it helps with their sleep and it helps with nightmares, for example. Some people find it makes nightmares worse, so it kind of depends on the person as well. There were a few questions about sleep monitoring, like Fitbits. I answered a couple of them, but I mean, generally, they're not. They can give some information. They're not like highly accurate. They're generally not medical grade devices. They're not as accurate as polysomnography. And we don't want we don't want patients to obsess more about their sleep. And I mean, I just got this free trial of one called a Whoop. I've never had a smartwatch. I've been using it for about 5-6 days, and I look at the app in the morning, it tells me when I've been awake, and I'm like, this is actually making me much more obsessed with my sleep, whereas I didn't really worry about my sleep before, and how often I was waking up in the night and things like that. And actually, I think it can increase the obsession about sleep. And what we want to do is reduce anxiety about sleep, because anxiety about sleep keeps people awake. We don't want to start, making it an artificial monitoring thing. We want people to develop a more natural relationship with their sleep, whereby we go more based on how they're feeling rather than what a particular kind of smartwatch says. So, we kind of recommend people aren't using the smartwatches. They use like the sleep diary more to talk about, how they feel the night went and how they feel in the day, because that's a much better way to kind of go about things. Zapalon, I think it used to be an option. It's very short acting Z drug, but it's no longer available. What else? We appreciate this session can be extended. I mean, yeah, we've carried on talking because we know there's a lot to cover. So but we can go for
Someone's
another.
asked about gabapentin, pregabalin. I mean, we wouldn't use that for insomnia specifically, but actually within the sleep world, they're our first line drugs for restless legs. The licensed treatment for restless legs in the UK are the anti-Parkinson's drugs, but they come with a whole host of problems, including paradoxical worsening of the restless legs in a very significant proportion of patients. So, in the sleep world, we use those for the treatment of restless legs.
Someone said, I don't fully understand this question. Could you please share the study regarding falls risk increase in 3 months before prescribing sedatives? Do you know, Hugh, what that relates to?
Yeah. So just to say, I mean, it's a recent study. I don't have the reference in front of me, but if you email me, I can dig it out for you. But it was just this demonstrating that actually the biggest risk of falls when people are prescribed hypnotics is not when they're on the hypnotic, but in the 3 months prior to being given the hypnotic. And that suggests it's not though there's an association, it's not actually the hypnotic that's causing the falls. It's more likely to be the insomnia. And actually, there has been a trial in US, not a trial, a retrospective study in US care homes that showed very much the same thing, that actually the big risk, the people most likely to fall are people with untreated insomnia, and people with insomnia who are given hypnotics actually have a slightly lower risk of falls. So, it's not that the medication is causing the problem. It's more likely that the insomnia is causing the problem.
Someone asked about doxepine. I know doxepine dose, and you replied 3 to 6 mg. My understanding is that's in this country you can only really get it to that dose if you buy liquid. Is that still the case, Hugh?
It's very difficult to get and it's very expensive. You can get 10 milligram capsules. That's the closest that we've got. Michelle has asked us, unfortunately, we do need to wrap up. I think everyone needs to head home and get a good night's sleep tonight. So we're going to stop there. But yeah, please, do get in touch if by email if you've got more questions. And we really do encourage you to come and join us on the CBTI day in October.